Welcome everyone to this IMID Forum EULAR 24 review podcast. My name is Sofia Ramiro. I'm a rheumatologist and senior researcher from Leiden University Medical Center from the Netherlands. And it is my pleasure to be here together with my colleagues and friends who actually don't need introduction, but they are Rieke Alten from University Medicine Berlin from Germany and Laura Coates from the University of Oxford from the UK. And together we will go through main topics of this EULAR dealing with treatment for RA, PSA, and axSpA. So, Rieke, the floor is yours first. Please go ahead.
Thank you very much, Sophia. So actually, we are all back from a very wonderful EULAR meeting in Vienna. And I'm going to share with you the data on rheumatoid arthritis. Actually, I think it's moving already. First of all, I start with the safety data of filgotinib in patients with moderate to severe active rheumatoid arthritis for 4.3 years. So we know that all the integrated safety analyses from clinical trials have shown that safety and tolerability is broadly similar between the different FIL dosages, with the lower incidence of herpes zoster with FIL 100 milligram versus 200 milligram. And you can see here in these results that the adverse events of special interest, including MACE, VTE, non-melanoma skin cancer, malignancies, excluding non-melanoma skin cancer, serious infections, herpes zoster, and all-cause mortality were comparable between the data cut, which were done in 2022, and the current analysis. The duration of exposure was shorter in the FIL 100 group, around 5.2 patient years, than in the FIL 200 group, 8.9 patient years. Comparisons of special interest between the treatment groups should therefore be made with caution. Over 312 weeks, the risk of all-cause mortality was similar for FIL 100 and 200 milligram, so that I can summarize these helpful data for our daily clinical practice. The safety profile of FIL remained stable over time, as you can also see here on the curve, and was similar to previous analysis. There was no new safety information concerning RAs of special interest which could have been identified. So another interesting slide were the comparison of two dosages of baricitinib, 2 and 4 milligram, for the treatment of moderate to severe rheumatoid arthritis. We are very thankful that we have these two dosages in our daily clinical practice. And here we have the investigation of the efficacy and safety of bari in the different dosages for the treatment of patients with moderate to severe rheumatoid arthritis, despite adequate treatment with methotrexate. Coming to the results, in the week 24 low disease activity and remission for the DAS28 CRP, we have around 80% on bari 4 milligram and around 45% on bari 2 milligram. And this data are true for all other outcome measures, for CDAI, for SDAI, and interestingly, we also saw interesting data on safety. For herpes zoster, we had only 2 cases in the 4 milligram group and only 1 case in the 2 milligram group. Then there was an interesting event, which I have, by the way, never seen in my patients. It is called skin eruption or itching. There were 11 patients in the 4 milligram group and 5 patients in the 2 milligram group. I see some patients with a so-called acne, but I have never seen patients complaining of itching. Maybe this is the same, what they have described here. It was not so clear for me. And then interestingly, also the data for renal impairment were higher in the 2 milligram group. But I think this is due to the more elderly group, which is more often prescribed the 2 milligram dosages. So bari 4 milligram was more effective than 2 milligram in patients with rheumatoid arthritis with an inadequate response to methotrexate. But in summary, there was no significant difference in safety between the dosage groups. But I think we have to take care also into account the renal impairment in our elderly patients. And sometimes I have patients who also take the 2 milligram dosage every second day. It's very interesting. So Peter Taylor presented very nice data from the BeReal study. on the association between patient-reported pain and achieving remission or low disease activity at month 3 in patients with rheumatoid arthritis. So this is a well-known study which has already most data being published. And we can see here the key results that over 90% of the patients across the treatment cohorts had at least moderate pain in the beginning at baseline. And we have seen in the results that a higher percentage of patients receiving baricitinib achieved a pain improvement in all analyzed thresholds compared with the cohort in the other, cohort B, in the other mechanism of action at month 3. This was, by the way, also observed in the later course of the study. And the patients on baricitinib experienced more than 50 and 70% pain improvement versus the other mechanism of action. A very interesting study. We saw a similar study by Peter Taylor in the same session where all these data were applied to upadacitinib and definitely very comparable results also for UPA. So here coming to the results for Bari-treated patients were more likely to achieve pain control compared with TNF inhibitors or other mechanisms of actions, despite having a longer disease duration and also a higher number of previous treatments with BO or TSD months. Very nice data also here for Bari. And then I saw the presentation by Paul Emery. Everybody expected these data on abatacept versus adalimumab in a head-to-head comparison in adults with early dual seropositive rheumatoid arthritis, positive especially for the shared epitope, and an inadequate response to methotrexate. Result from the so-called phase 3 amplified trial. It was a little bit a copy of the early AMPLE trial, which also Emery presented earlier some years ago. And the challenge was to show when the clinical profile patients have shared epitope, double seropositivity, and have not an adequate response to methotrexate with very early rheumatoid arthritis, there would be a superior response to ABA compared with adalimumab, both on the background methotrexate therapy. But unfortunately, the primary endpoint of this study at week 24, ACR50, was not met. So he was a little bit disappointed when he presented the data. Actually, I think there must be some post hoc analysis. In my own patient, I see very, very good responses in the double seropositive with shared epitope patients, and they have a very, very stable adherence to abatacept over a long time. But the data are the data. And actually, that was interesting that the response of ABA and ADA was absolutely comparable. You can see also here the three curves for 20 ACR 50 and 70, and they were really overlapping. There was no differences. So then my colleague Gerd Burmester really did do a mountain work, really going up a mountain. He collected the safety of UPA data across rheumatoid arthritis, PSA, and axial SPA, encompassing 15,000 patient years of clinical trial data, a huge amount of data. So what we can see here are interesting results. The rate of serious infection was higher with UPA, 15 milligram in comparison to ADA in the PSA patient population. Herpes zoster and elevated CK were reported more often with UPA 15 milligrams versus the active comparators in rheumatoid arthritis and also in PSA. And also, interesting result, higher rates of non-melanoma skin cancer were observed with UPA versus the active comparators in RA and PSA. So this shows, again, the need of very high quality real world data, especially what we need more and more is for axSpA, to further contextualize and confirm these findings. I think that is somehow an interim analysis, but I was a little bit astonished by the data because they are not reflected in my daily practice, but this is why we need these real world data to see all our personal experience on a broader view. So I'm done with my rheumatoid arthritis abstracts for this EULAR, and I thank you very much for your attention.
Thank you very much, Rieke, for this very good overview of those that were highlights of the treatment of RA at EULAR. And now we will move to PSA, and the word is to you, Laura.
Lovely, thank you very much. So this is to run through the psoriatic arthritis highlights, and we had a few new medications showing trial data at EULAR this year, which is always good to see. So this is data from the phase 2b trial of TAK-279. This is a TYK inhibitor, so a bit like a JAK inhibitor, but not quite. This is a selective TYK2 inhibitor. And looking at their randomized double-blind placebo-controlled trial. This data was shared at ACR last year as a late breaker, and then again at EULAR this year. So what you can see here is that they looked at different doses of the TAK-279, a 5 milligram dose in the grey, which didn't seem to do so well, the 15 milligram dose in purple, and the 30 milligram dose in the green. And both the 15 and the 30 milligram dose achieved significant benefit compared to placebo for ACR 20, 50, and 70. And if you can see from the graph above that there's a relatively rapid response around week 2 and week 4, where patients are starting to respond to treatment. Interestingly as well, if we look at the data for the PASI score, it seems that the higher dose, the 30 milligrams, was more efficacious than the 15, whereas with the joint outcomes, they looked about the same. You can see on the far right-hand side the issues around safety reported in this trial. It's obviously quite a small study, but no worrying or new issues that were identified. Because this is a more selective TYK2 inhibitor, we would expect to see slightly lower rates of abnormal blood results associated with treatment. So this is definitely a further evidence around the use of TYK2 inhibitors in PSA, and has shown evidence for both the 15 and 30 milligram dose, and there will be further studies which are in development at the moment to look at this in phase 3. Another new medication with a phase 2 trial was sonelokimab. This is a novel nanobody. It's much smaller than a monoclonal antibody that blocks both IL-17A and IL-17F. And this was again tested in psoriatic arthritis in a double-blind phase 2 trial. So here you can see placebo in grey compared to 3 different doses of sonelokimab in the purple. And in this small phase 2 trial, they also had an adalimumab internal comparator group. So this isn't a powered head-to-head study, but it gives you a little bit of a kind of reference arm in the form of that adalimumab data. What you can see here is that there's good outcomes for ACR 50, which was the primary endpoint of the study, also ACR 20, and then higher bars as well. So looking at achievement of MDA, the composite of ACR 50 plus PASI 100, or ACR 70 plus PASI 100, and a good improvement in patient-reported outcomes with the PSAID score. It looked like there was a lower response, particularly for the higher bars, for the lowest dose of sonelokimab tested. So that was a 60 milligram dose, but without an initial loading period, as opposed to the 60 milligrams with the loading dose, which seemed to show slightly better, or at least slightly more rapid response. So I presume we will see those 2 doses of 60 and 120 in the future phase 3 trials. So this obviously is another IL-17. We've had these before, but a very different drug in the form of a nanobody and something that blocks IL-17A and F. This study presented by Stephanie Werner was data from the UpJoint study. This is a study looking at upadacitinib for treating psoriatic arthritis in real-world practice, and it's recruiting in Germany and Canada. So this was a relatively large study where patients were about to start on upadacitinib as part of their standard of care, and then they collected data over the first year of treatment. And it's particularly useful because I think it gives us the first good quality data looking at oligoarthritis with upadacitinib. Obviously, the main trials tend to recruit very polyarticular patients, but what you can see here is responses for those who started with oligoarticular PSA and those who started with polyarticular PSA. And they've looked at these different outcomes, including achievement of minimal disease activity and very low disease activity. So they actually had slightly more polyarticular than they did oligoarticular patients, but nonetheless, a decent number of oligoarthritis patients reviewed in this study. And you can see a slightly lower chance of achieving very good outcomes like MDA or VLDA for those who start with polyarticular disease. So if you've got many joints involved at baseline, it's harder to get to the point where you have only one tender and one swollen joint. So actually you see slightly better outcomes for the oligoarthritis patients in terms of MDA and VLDA, as well as the HAC, which presumably is a function of the number of joints involved. As you'd probably expect, no real difference with skin disease because the patients will have a variety of different skin involvement across the oligo and polyarthritis. So I think it's really helpful to have data, obviously building on the phase 3 program with upadacitinib, which shows that it also works in terms of improving outcomes for those who have oligoarthritis as well, who are not usually included in the original phase 3 studies, or at least not as commonly. And then on a topic of oligoarthritis, looking at data from the Foremost trial. So this isn't the first time data from Foremost has been released, but this is data looking out to 48 weeks. So this was a specific study in oligoarthritis. They recruited patients who had 2 to 4 joints, tender joints at baseline and 2 to 4 joints, swollen joints at baseline, and they were treated with either apremilast or placebo. And we've seen data previously from the week 16 showing that there was a benefit for apremilast over and above placebo, and the primary outcome was MDA joints. So MDA where you had to meet the joint criteria. What I think is interesting is looking at the longer term outcome of this and the changes in joint count. So what you can see in the graph on the top right is that actually there was a relatively rapid increase in the number of involved joints in patients during the trial. That was clearly different for those receiving apremilast in the orange compared to those receiving placebo in the blue. But even on apremilast, we saw nearly 20% of patients go from oligoarthritis to polyarthritis. And in the placebo group, that was nearly 35%. So quite a rapid escalation in disease activity that makes us question how much worse those patients have got in quite a short space of time. But as you can see beyond week 16, the patients who were on placebo then switched to active drug at week 24, and their proportion of those patients having polyarthritis then drops rapidly. So they're responding, and they're responding very well. The lines then look pretty parallel. But in that initial phase, when they're not receiving active therapy, there is a very rapid increase in the number of joints involved. And they also shared the rest of the data around week 48, thinking about DAPSA outcomes, patient-reported outcomes like PSAID and HAC, showing a good improvement and a sustained improvement out to week 48 in those receiving apremilast. And then finally, the last abstracts I'm going to cover from PSA. There were an amazing amount of abstracts at the conference this year looking at routinely collected data and how we use that to learn more about treatments and outcomes for patients. And obviously there's a vast amount of big data that's collected by a lot of databases, electronic patient records, pharmacy records that we can use to try and understand care, but I think we have to have some caveats with this. So this study looked at treatment persistence, so a rough correlate of outcome, but not obviously looking at joint counts directly, with patients who received IL-23, guselkumab, and patients who received TNF inhibitors. And the patients on guselkumab were significantly more likely than those receiving the IL-17 to stay persistent on drug over time, and that seemed to increase over a sort of a 12-month period. So this data suggests much better outcomes for those receiving IL-23. But I think we have to have this caveat. They did use propensity score weighting to try and match the groups, but there are going to be a lot of reasons why patients start on a TNF inhibitor, an IL-17, an IL-23 inhibitor in PSA that will not be recorded in this kind of data, and that we won't be able to match for. We can match for sex, for age, for disease duration often, but we can't match for things like active psoriasis, how many drugs people have previously failed, or any other reasons why we are picking one drug over another in clinic. So I think we just have to be a little bit cautious, and future studies looking at longevity, ideally in randomized controlled trials, will be really important to see if this holds up in good quality, well-designed prospective studies. So that's the summary on PSA from EULAR, and I'll hand back to you, Sofia.
Thank you very much, Laura. Very interesting to see that. Indeed, I think you are the lucky one because you could present new trials with new data, which was not the case for RA and neither for axSpA. And indeed, I could not agree more with your comment of the importance of having data from real life, but at the same time of having the caveats of confounding by indication that we cannot forget, and I am very happy that you have extensively highlighted it. So without further delay, we now move to axSpA, and we will be going through the highlights of axSpA, also through some abstracts. We will start with data from the upadacitinib trial, the SELECT AXIS-2, which had been previously presented, but here we have for the first time 2-year data from this study. So the study deals with the efficacy and safety of upadacitinib in patients with non-radiographic axSpA, and we have data at 2 years. As we can see on this graph here, we have the primary endpoint ASAS40, where we see that the primary endpoint was met, as we already knew before, at week 24, and it was kept. Response is kept until 2 years. We also see that patients who first got placebo and later were switched into upadacitinib, they also reached comparable levels of ASAS40 to those that were initially randomized to upadacitinib from the beginning. And we could be showing similar graphs to several other outcomes on disease activity, like ASDAS or ASDAS low disease activity, or outcomes on function, BASFI, health-related quality of life with ASQUAL and ASAS Health Index. We see actually that the response is sustained, and there are no major findings in terms of safety, as in line with what one would expect and what we know from the safety pattern of upadacitinib that we have already heard in this podcast today. Moving to another molecule, and now we have the trials with the bimekizumab, B-Mobile 1 and 2, trials with radiographic and non-radiographic axSpA. The main results of these trials have been previously presented, but we have new data presented at the EULAR. And this new data deals with structural damage progression. And this first poster by Walter Maksimovic, we see the effect of bimekizumab on structural lesions. In this case, on the graph, we see erosions, but also on fat lesions and ankyloses, the effect was evaluated. And at the same time, in the same abstracts, we looked again into the effect of bimekizumab on inflammatory lesions so that we can have a parallel and see what happens on the one hand on inflammation, on the other hand on structural lesions. And indeed, we see that inflammatory levels on MRI of the SIJ improve throughout the study. And we see that erosions, there's a change in the erosions from baseline where they decrease with bimekizumab more than with placebo, and we see that here in both studies. And there is an increase in backfill and fat lesions, and there is actually almost no change in ankylosis throughout the trial. So it seems like we see an effect of the drug on structural lesions as measured on MRI of the SIJ, and these were measured at the timing of the primary endpoint at 16 weeks and also up to 52 weeks, as we see on the graphs. This is a quite hot topic in the field because, of course, we are always trying to identify drugs that can inhibit structural damage progression. Structural damage progression is nowadays, in principle, still measured on conventional radiographs, but particularly in axSpA, the progression is relatively slow, so it's good to look for surrogate markers, and MRI structural lesions appear to give that possibility. On the other hand, at the same time, we don't know exactly what is their predictive validity, so I think we are at the stage at trying to understand more of their role and whether we can really use them as surrogate markers for what means structural damage progression, but encouraging data with the bimekizumab. Continuing within the same trial, and it's actually in this case only the trial of the radiographic axSpA, and within the topic of structural damage progression, but here structural damage of the spine. And in this study, or in this post-hoc analysis, we have looked into the effect of the bimekizumab on MSAS and 2-year progression of structural damage in the spine in these patients. The challenge, as I was mentioning before, with the measurement of structural damage progression is that it takes a long time. So we can only capture structural damage on radiographs after at least 2 years, and it's of course not possible to have a placebo-controlled trial of 2 years. So that means that all of the patients that in whom structural progression of the spine was analyzed have received bimekizumab. Some of the patients received it throughout the whole period. Other patients received it after week 16, after the timing of the primary endpoint. And they're both groups plotted in this cumulative probability plots. We do not see differences between both groups, and in general, we see very low progression. So we know that the mean baseline MSAS in this trial was of 7.3. And there was a change over 2 years of 0.3 at the group level, which is a very low change. If we look at the proportion of non-progressors, if we define them up to an MSAS of lower than up to 0.5, then 85% of the patients were considered non-progressors. And if we consider an MSAS up to less than 2 as non-progression, then 92% of the patients are non-progressors. So there's very little progression in this trial. This also led to not identifying any potential predictors identified with progression in this trial, as there's little progression over time. Again, encouraging, it seems that there is very low progression. However, we do not have, for the reasons I mentioned, the possibility to have a comparator group within this trial, so we cannot take hard conclusions without that. Now moving to another treatment option, ixekizumab, IL-17A inhibitor, on which a post-hoc analysis was also conducted on the structural lesions as assessed on the MRI of the SIJ. So in fact, comparable analysis to the previous one I showed you in bimekizumab in the B-Mobile trials, and here the same analysis was conducted in COAST-V trial, the trial with ixekizumab in patients who are biologic naive, with patients with radiographic axSpA. Here we also see that there is a reduction in the erosions over, if we compare ixekizumab to placebo. So if we look at the blue bar, for example, that's ixekizumab every 2 weeks compared to placebo, which was the gray bar, in which there was actually even an increase in the erosions. The same reduction was seen with adalimumab as well, although the trial is not powered to compare those two arms, so we can only compare them to placebo. On the right-hand side, we see the graph with black fill, in which still seems to be increased as was expected. And then there were some subgroup analyses that were done, and they confirmed the same that was found in the same analysis in terms of reduction of erosions in the subgroups of males, HLA-B27 patients, and patients who have inflammation on the SIJ on the MRI. So in summary, a 16-week ixekizumab treatment decreased erosion scores, increased backfill, particularly with the ixekizumab every 2 weeks. It is possible that these changes are consistent with the tissue repair and then actually rapid tissue repair, but also for that, it is very difficult to have a definite conclusion because we cannot have histological studies, we cannot have a confirmation that these changes that we are seeing on MRI really reflect tissue repair and restoration of the function, but there's our hypothesis, and this is all still being further investigated. Now moving to another study, and a study from the trial from the group from Ghent, in which the group included patients with very early axSpA. All patients had less than 1 year of symptom duration, and actually this qualifies as the first trial conducted only in patients with early axSpA. So the trial aimed to evaluate the efficacy of an approach that is reflecting the recommendations in a treat-to-target approach, in which patients were started with NSAIDs, and when they did not have an ASDAS improvement of at least 1.1 points, so a clinically important improvement, or they did not achieve an ASDAS in active disease, so below 1.3, then treatment was intensified. And if response was not achieved with another NSAID, then biological DMARD was started, and according to protocol, that was in this case monotherapy of golimumab. And what do they show to us after 1 year of treatment? Actually, that 62% of the patients achieved sustained clinical remission, which is a very high proportion of patients. And in additional, 22% of patients achieved low disease activity, which means that only a very low proportion of patients, only 16% of patients, had high disease activity after a year. I have to add that inactive disease was defined after the presence of ASDAS below 1.3 in 2 consecutive visits after a period of 12 weeks. So it's quite a permissive definition because it's a relatively short period to define remission or sustained clinical remission, as the authors defined. But still, it shows very good results that unfortunately we do not have a comparator, so we cannot very easily put them into context when it's an open label trial, not blinded and without a comparator group. After 1 year and per protocol, those patients that were in inactive disease, then the treatment was stopped, and within the next year of follow-up, then it was assessed whether patients flared, and actually 85% of patients flared. So, which is a high percentage and something we are in line with what we know from before, that immediate discontinuation of treatment is not very desirable and is associated with a relatively high likelihood of recurrence of the disease. Authors also looked into, and we have here a table on the right-hand side with the predictors of inactive disease and who were the patients most likely to achieve inactive disease after 1 year. And those were male patients, patients that never smoked, and patients that had at baseline lower BASDAI. So those were associated with higher likelihood of achieving the good outcome, in this case, remission. And now moving to the last abstract, I will be summarizing on axSpA highlights. We have the hot topic of the safety of JAK inhibitors and the fact that we, of course, do not have a trial like oral surveillance in axSpA. So we have to do with observational data and data that is coming out of long-term extensions and observational studies. This is a very large study coming from the TRINEX collaboration, in which authors have looked at the risk of cardiovascular disease, VTEs, and common cancers, and compare them between JAK inhibitors, TNF inhibitors, or IL-17 inhibitors in patients with SPA, considering both PSA and actual SPA. We have a large number of patients that could be included in the analysis, so almost 3,000 patients with JAK inhibitors and more than 30,000 patients with TNF inhibitors. They used propensity score matching, which completely goes in line to what Laura mentioned previously on PSA, so it addresses to some extent confounding by indication, but it never completely adjusts for it because there are always unmeasured confounders. But if we look at their results, so compared with both TNF inhibitors and IL-17 inhibitors, JAK inhibitors were not associated with an increased risk of CVD, VTEs, or cancer at 1 year. And in this table, we have the results at 1 year, 3 years, and 5 years, and the results were consistent. And I think we have a kind of a positive comparator, a positive control in this study, which is the incidence of herpes zoster, which was confirmed to be higher in JAK inhibitors. If it was not the case, then it's something we know happens more with JAK inhibitors, then we would be more worried about the validity of the findings. But so indeed, a higher risk for herpes zoster is found with the JAK inhibitors as expected. And this brings me to the end of this axSpA highlights, and at the same time also brings us to the end of this review podcast. So I would like to thank you very much, my colleagues Rieke and Laura, for their brilliant summaries, short but concise, and with the most important updates and highlights on treatment in RA, PSA, that I could continue with axSpA in this podcast. And I will invite you all to go to the website of the iMeetForum.com, where you can listen to this podcast and to other data and summaries that we have from the EULAR Congress. Thank you very much for your attention.